The disease with 1,000 faces. Difficult to diagnose, complex, and chronic. It will strike 1 in 900 Canadians. Lupus. This autoimmune disease alters patients' lives, and if left untreated, can be fatal. At the BC Lupus Society, we provide support to people living with lupus. Because lupus is unpredictable, we strive to be dependable. Our programs include weekly support groups for patients and families in British Columbia. We make sure that educational resources and peer contacts are always available, including for patients facing a new lupus diagnosis. And every year, we help fund clinical training and medical research that benefit people with lupus. Through the BC Lupus Research Scholar Program, our goal is to advance treatments and discoveries to change the future of lupus. Our partnership with university researchers is unique in Canada and has helped understand the full impact of lupus and the effectiveness of lupus care. As part of our community, you're a valued part of annual events like our Lupus Gala and the Shed Light on Lupus Walk. These fundraising activities generate just part of the funds needed to sustain our work in patient support and medical research. With the generous support of donors like you, the BC Lupus Society will continue to be here for patients and families affected by lupus. Not only can we change tomorrow, we can brighten today. Thank you from the BC Lupus Society.
Dr. Azin Ahrari, and I'm a rheumatologist and a clinical instructor at University of British Columbia. I practice at the Lupus Clinic at Mary Pack Arthritis Centre in Vancouver, BC, and I'm also a consulting rheumatologist at Surrey Memorial Hospital in Fraser Health Authority. It is my pleasure to be speaking with you all today at the 33rd Lupus Symposium about management of lupus beyond prescribed medications. So let's get started. The objectives of my talk are to discuss the important aspects of care for patients with SLE beyond the prescribed medications. That includes sun protection, vaccination, age-appropriate malignancy screening, cardiovascular health, and bone health. So let's start with a case. Mrs. L is a 39-year-old female with lupus that manifested 2 years ago with a malar rash, joint swelling, hair loss, anemia, and lupus nephritis. She was treated with hydroxychloroquine, prednisone, and mycophenolate mofetil. She responded well to medications, and her lupus is now in remission. She is taking hydroxychloroquine and mycophenolate mofetil. Aside from pharmacologic treatment, she's interested in learning about other important aspects of her lupus care. Specifically, she has heard that it's important for lupus patients to protect themselves against the sun. So she's wondering, what are the recommended sun protection strategies in patients with SLE? Furthermore, she has done some research and learned that patients with SLE are at increased risk of certain malignancies. So she's wondering, what are the recommended age-appropriate malignancy screening strategies in patients with SLE? And finally, she has been told that her medications are immunosuppressive and increased risk of infections. So she's wondering, what are the recommended vaccinations for her to protect her against infections? So let's talk about sun protection with SLE. Why is it important for patients with SLE to protect themselves against the sun? It is important because UV exposure causes damage to the cells and the DNA. And in patients with lupus, the damaged cells by UV radiation have a lower rate of clearance. And the fragments of dead cells can trigger an immune response in lupus patients. So in patients with lupus, UV exposure can actually trigger an immune system response that leads to any of the symptoms, including sunburn, skin rash, joint pain, fatigue, and other symptoms. Additionally, Some of the medications used in lupus can actually increase our sensitivity to sun, for example, hydroxychloroquine. So for these reasons, it is important for patients with lupus to have excellent sun protection strategies. So you might ask, what are the steps of sun protection? First step is to choose the right sunscreen. UV is comprised of UVB and UVA, and lupus patients can be affected by both UVA and UVB. A broad spectrum sunscreen can protect against both UVA and UVB. The sun protection factor, or SPF, that you might note in a bottle of sunscreen, on a bottle of sunscreen packaging, indicates how long you can stay in the sun without burning compared to not wearing sunscreen at all. For instance, if your skin starts to turn red in the sun after 10 minutes, applying an SPF 15 sunscreen should allow you to stay in the sun for about 15 minutes without burning. The higher the SPF number, the more protection it will provide to your skin. And star rating on a scale of 0 to 5 indicates the level of protection sunscreen provides against UVA radiation compared to UVB. So you would like to choose a sunscreen that has a high SPF, 50 or higher, and good rating. After you've chosen the right sunscreen, the next step is to apply it properly. Sunscreen should be applied 20 to 25 minutes before going outdoors to allow for it to activate and actually protect the skin against UV radiation. We have to ensure that we are applying enough sunscreen, and that on average is 2 tablespoons needed to cover an average adult body. Thirdly, we have to reapply sunscreen approximately every 1 to 2 hours, and especially if you're being active and sweating. It's important to note that chlorinated water can actually inactivate the components of a sunscreen, and so we must reapply as soon as we leave a pool if we're going to be staying outdoors. If you are going to use other cosmetic products or skin products, apply the sunscreen first to your skin. We also have to protect our lips and ears. So don't forget to put sunscreen on your ears, and don't forget to put a wax-based lip balm of SPF 15 or higher on your lips. Products that are labeled water resistance for 40 to 80 minutes can actually protect you for that duration of time at the stated SPF on the packaging while you're swimming or being active and sweating outside. And it's important to note that sunscreens have an expiration date, and we should not use them after their expiration date. And if there is no expiration date on the bottle, then discard it if they're more than 3 years old. In addition to wearing sunscreen, there are other important aspects of sun protection, and that means wearing a hat, using sunglasses, using sun protective clothing, and most importantly, don't forget to wear sunscreen even when it's cloudy outside, because even when it's cloudy, there is still UV radiation that we are exposed to when we're outside. So the next aspect of our talk today is going to be talking about vaccinations in SLE. Infections are the leading cause of mortality and morbidity in patients with SLE, and this is due to 2 main reasons. One is disease-related, and second is medication-induced changes in the immune function. Patients with SLE carry an increased risk of infection due to their altered immune status, and immunosuppressive drugs that are used for treatment of lupus, such as corticosteroids or cytotoxic agents, can further impair the immune response to pathogens. So vaccines are the cornerstone of infection prevention. Despite the theoretical risk, of disease flare following vaccination, or possibly impaired antibody response to vaccination in patients with SLE, there is also plenty of evidence that shows vaccination is effective and protective against infections in patients with SLE. So here is a very quick review of the latest data in the field of vaccinations in patients who have SLE. So first, let's talk about pneumococcal vaccination. Respiratory infections are one of the most common causes of infection in SLE patients, and Streptococcus pneumonia is one of the most frequent pathogens associated with mortality and morbidity in respiratory infections. Pneumococcal vaccination is strongly recommended for patients with rheumatic diseases such as SLE who are taking DMARDs, that is suppressing their immune system. This vaccine includes receiving a PCV13 followed by a dose of Pneumovax or PPSV23 at least 8 weeks later, and a booster of Pneumovax can be administered every 5 years. If a patient is going to be on rituximab for their lupus, it is ideal to start the vaccination prior to initiating treatment with rituximab. Or if rituximab has already been initiated, it is ideal to wait 6 months since the last dose of rituximab and 4 weeks prior to the next dose of rituximab. If a patient is on belimumab or other immunosuppressive drugs like mycophenolate mofetil, then they can follow the recommendations that are advised for general population in terms of the timing of their pneumonia vaccination. Another vaccine that is commonly used is influenza vaccine. And there is evidence for lower seroprotection and seroconversion compared to healthy populations. However, despite this lower seroprotection and seroconversion, the inactivated influenza vaccine still offers a great deal of protection against influenza for patients who have SLE. And therefore, it should be recommended for all patients annually. Again, if you are going to be taking rituximab, it is ideal to take the vaccine prior to initiating the rituximab dose 2 to 4 weeks prior to initiating the dose of rituximab. For other medications like belimumab, the vaccination can be administered at any time, similar to general population. Another vaccine that we have commonly been using now in patients with SLE is the COVID-19 vaccination. And this is because autoimmune diseases and notably use of immunosuppressive medications like corticosteroids and cytotoxic drugs or B-cell depleting therapies are actually associated with more severe COVID infections and worse outcomes. And so COVID-19 vaccination can help protect against SARS-CoV-2 infection to some extent. And if a patient is receiving rituximab, it is advised that they receive their COVID-19 vaccination 6 months after the last dose of their of their rituximab and 2 to 4 weeks prior to the next dose being administered. For other medications like belimumab or MMF, the vaccine can be administered at any time and does not need to be timed with their medication. And finally, varicella vaccination or shingles vaccination. The prevalence of herpes zoster in lupus patients is slightly higher, and it has been rated as high as 30%. And this is because of factors such as lymphopenia and glucocorticoid use that actually increases risk of shingles infection. And so many patients with lupus, depending on their risk factors and depending on the medications they're using, may benefit from receiving shingles vaccine. And shingles vaccine should be administered to patients that are high risk and over the age of 50. And if they're going to be receiving rituximab, it is best that it's given 6 months after the last dose of rituximab and 4 weeks prior to their next dose of rituximab. And what about age-appropriate screening or malignancy screening? As you know, there are recommendations for the general populations for age-appropriate malignancy screening when it comes to cervical cancer, breast cancer, and colon cancer. And most of these recommendations are similar for lupus patients as well. However, cervical cancer screening is a little bit different in patients with lupus. The general population is recommended to have cervical cancer screening every 3 years between the ages of 25 and 69 if they've ever been sexually active. However, patients with SLE are, and particularly those who are on immunosuppressive medications, likely have an increased rate of HPV infection, cervical dysplasia, and cervical cancer. And as a result, it is recommended that patients have an annual cervical cancer screening up to age 69. However, it is important to note that this is a conditional recommendation based on the SLE working group research, and there is no strong data to support this because there is no research studies directly comparing the different cervical cancer strategies in patients with lupus. So, if you are wondering about how often you should have cervical cancer screening, I recommend discussing that with your rheumatologist. And depending on the risk factors that you have and the medications you are taking, they will help you find the right rate of screening in your case. Other age-appropriate malignancy screenings are very similar in lupus patients and the general population. For example, breast cancer screening is mammography every 2 years between the ages of 50 and 74. Again, this is subject to other nuanced factors such as risk factors or family history of breast cancer. And colon cancer screening is with FIT or colonoscopy that's recommended between ages 50 and 74, and between ages 75 to 84. It depends on the patient's risk factors as well as risk of colonoscopy. If someone has a personal history of precancerous lesions, a personal history of colorectal cancer or inflammatory bowel disease, or a family history of colorectal cancer, these recommendations are altered. So again, discuss with your family doctor or your rheumatologist about the frequency of colorectal cancer screening and breast cancer screening in your case if you have lupus. And lastly but not least, let's talk about osteoporosis and cardiovascular risk assessment in patients with lupus. We know that adults with SLE are frequently exposed to corticosteroids, and that increases their risk of osteoporosis and fragility fractures. And so all patients with SLE should have an assessment of their osteoporosis risk and bone health every 1 to 3 years. And this will be done by their family doctor or their rheumatologist based on their history, physical exam, and bone density scan results. Bone density should be measured in patients who have had a history of fragility fracture or have been on corticosteroids for over 3 months. And it is also recommended in patients with lupus who are over the age of 50. So, discuss with your rheumatologist or your family physician about your bone health, and don't forget to screen for osteoporosis every 1 to 3 years. And finally, cardiovascular risk assessment. There is plenty of evidence in the literature suggesting that patients with SLE have an increased risk of cardiovascular disease as they age. And therefore, risk stratification and identifying their modifiable risk factors is very important for their care. Traditional risk factors for cardiovascular health are obesity, smoking, hypertension, diabetes, high cholesterol, and these should be assessed periodically by your family physician or primary care provider. And then there are lupus-specific risk factors, such as having antiphospholipid antibodies or having had neuropsychiatric lupus, elevated CRP, or chronic corticosteroid use. Again, These would be assessed by your rheumatologist and primary care provider to try and lower the risk of cardiovascular disease as you age. So, in summary, we talked about management of lupus beyond the prescribed medications like hydroxychloroquine or mycophenolate mofetil. And we know that it's important to address these other aspects of lupus care in order to reach the best outcome in patients with SLE. These include sun protection. We want to choose the right sunscreen, apply the right amount of sunscreen, and the right frequency of application in order to protect ourselves from UV radiation. Secondly, we want to use other methods of sun protection, such as hat, glasses, or sun protective clothing. We talked about vaccinations in patients with SLE and made recommendations based on timing of vaccination and their immunosuppressive medications. So don't forget to speak with your rheumatologist about the recommended vaccines in your case based on your risk factors and your medications. And we also discussed age-appropriate malignancy screening and learned that cervical cancer screening is recommended annually compared to the general population that's recommended every 3 years. This recommendation, however, depends on patients' risk factors and the medications they are using. So discuss that with your rheumatologist. And finally, don't forget to frequently have a discussion with your rheumatologist or your primary care provider about bone health and cardiovascular health in lupus, as these are important and can be addressed in order to improve the bone health and reduce risk of cardiovascular disease as you age. Thank you for your attention during this talk.